So I'm glad you didn't read my title from the program because, as you see, I've actually changed it. I decided to make it a little broader than I am going to talk about tibial acceleration and its role in understanding distance running, but I'm going to attack the rather broader problem that you face really every day. And many of you, I know, have a mixed practice, which includes sports medicine. And I think that your sports medicine patients are probably amongst the most voracious consumers of information from wherever they can get it. So they come to you brimming with internet quality knowledge, and you have to sort of manage their transition from injury to treatment, and you have to manage their expectations, which have been raised to a very high level by things that they have read in advance of coming to see you. So I'm going to talk about the rather general title of claims and counterclaims, and I've chosen biomechanics of running because it's an area that I've done some work in, and address the question of how does a clinician decide? I should add that I have, for this presentation, no disclosures, no commercial relationships, no financial interest with the material presented, and you see that I've included what might soon to be some foreign currency on the slide to just indicate that. So, in particular, how do you decide the veracity of information that comes your way regarding changes that might enhance performance or reduce injury? Now, this used to be a pretty simple manner. In the days when medical education really consisted of see one, do one, teach one, that's all there was to it. You would say, well, my chief taught me how to do this, and I did this, and it works, and that's what you should do. But those days have dramatically gone, and with the mantra of evidence-based medicine, with the growth of and proliferation of information from a variety of sources, it's now a much more complex task to decide what's true, what's false, what may be true, what may be appropriate for one patient, and what may be not. And I've chosen two current issues in the biomechanics of running to talk around this and explore it. One of them, you can't have avoided getting involved in this, in treating running patients. Do conventional shoes actually cause rather than prevent injury? And are minimalist shoes the solution? So this has been a very popular opinion set in the last 5 years. And the second one is rear foot striking an incorrect running style? And should you be taking patients who are rear foot strikers and changing them to be midfoot or forefoot strikers? And I know people who are doing this at very, very reputable clinics. And is it a good thing? Is it a bad thing? So let's embark on this little journey of exploration as to where you get your information from. If I have time, I'll throw in a little fun experiment we have recently done that doesn't have much to do with this, but let's see how we go. So here's your brain, and your brain inside its realm of knowledge, and you are subjected to information from a number of sources. We would probably think in the ideal world that you would get everything you need from conventional sources in science and medicine, and we'll talk about some of those, and we'll talk about, in particular, evidence-based trials, authoritative reviews, systematic reviews, and meta-analyses briefly. More and more, particularly and not only in sports medicine, industry has a big impact. You only have to be watching TV during dinner time to get all the ads from the drug companies about bowel medications and everything else that might impact your state, in your medical state, in the next 30 minutes after you've eaten, to know that there's a tremendous effort from industry to be the ones who are telling you what you should want, so that you go to your doctor and you say, this is what I want. And you put the pressure on your care provider to give you what you've been told by the drug company or a nutrition supplement company, or in my case, footwear company, what you should need. And we'll look at that. Popular press has become an amazing source of health information. Most of the major newspapers, at least the ones I read anyway, The Guardian, the New York Times, they all have their wellness columnists, their health columnists. They have the wellness blog in the New York Times on health, and they have columnists who are usually journalists, and they scan the literature and they cull the latest and they bring it to the blog, and then that becomes the flavor of the month. And so popular press has a much greater impact as far as the number of people that it reaches, mostly through web accessibility. Now, emulation is another area where you might get some of your information or decide that this is a path you want to follow to apply a particular treatment to a patient. So if something works in one context, or if somebody in sports medicine is very successful, it may be that you could graft elements of what they do or how they do it onto your current patient, and that might work. And so we'll talk a little about emulation. And finally, there's a lot of armchair scientists out there. There are people who are presenting hypotheses that are not verified, but the boundaries between what's real science and armchair science have become blurred. So these are at least 5 sources that you may derive your information from. There may be others, and by all means, please think of some and let me know afterwards, because I'd like to enhance this whole notion. So let's look at the popular press. There's the Well blog from the New York Times, for example. This is a great one. This is about runners who love beer. And it's how to, when to, if to, what to drink in relation to your exercise. More to the point that we'll be talking about later, here is a blog, Changing Running Form, My Journey to the Midfoot. This is about a runner who decided that he really did want to change his running style in a manner that we will discuss a little later on. Industry. So let's dive in and look at the impact of industry on footwear choices and what your running patients might be wearing because of what they've read. I snipped this morning from the website of REI, a major retailer of outdoor equipment, sports equipment, and it's not whether or if to choose minimalist shoes, it's how to choose minimalist shoes. And the quote that I've extracted down here says that it was preceded by, while a few hardy folks are running barefoot, most of us opt for minimalist footwear. Most of us opt for minimalist footwear. So here's an assumption on this blog that that's the way to do it. This manufacturer, this is what you do. The current thinking, as far as they're concerned, is that you must wear minimalist shoes. Now, these are the typical arguments that are made for proponents of minimalist footwear or barefoot footwear. I'm going to steer a little bit clear of barefoot footwear, but of course these two are very intertwined, because the barefoot footwear protagonists are saying that what they're doing is they're moving you back closer to a natural form of running barefoot. And here's what most people say. First of all, that shoes filter sensory input that you need for injury prevention. Now, I think this argument has some merit to it, in the sense that the plantar aspect of the foot is one of the most sensory-rich areas of the body. I think you probably have all seen the sensory homunculi, where the body is represented in size by the number and richness of sensory organs that are in it. So when you see this sensory homunculus, it has huge lips, huge genitalia, and huge feet, because that's where all the sensory input, the majority of the sensory input is. But just because that's true doesn't necessarily mean that we are losing important information for injury prevention by attenuating some of the sensory input. why would you want to run on a bed of nails? To me, that association isn't necessarily a good one. You have lots of other sensory receptors. You have receptors in all the joints of the lower extremity. You have receptors in all the muscles, all the tendons, in the soft tissue. So even though it is true that there's going to be some attenuation of sensory input, I don't think it's a really good argument. Shoes can cause instability. Well, this certainly is another argument that has some merit. You're going, in general, in a cushioned shoe to have more movement during the contact phase than you are when you're wearing barefoot, when you're going barefoot. But again, that's not necessarily a bad thing. That may allow you to do some adaptation that your joints cannot, but it's an argument that's frequently used. Another one, early hunters never wore shoes. Well, this is, in fact, the most popular argument. And so, well, unfortunately, they didn't have a shoe store just down at the next cave to go to try out some shoes on. So I'm not so sure that that's an argument. But Lieberman, who I'll talk about a little later, does argue that because of Darwinian evolution, which always emphasizes and perpetuates characteristics that are advantageous, that the feet that have emerged as they are today would have preserved the characteristics, and if barefoot running was the way to do it, then they would have preserved the bare feet that were most advantageous. Now, that is a relatively long-term argument for a short-term evolution. I mean, our recent ancestors who were not shod on an evolutionary scale are really very, very recent compared to the massive evolutionary changes that we have seen occur since we diverged from other species such as the chimps and the gorillas. So I'm not really convinced by that one. Shoes cause unnatural changes in running style. And basically what this one is that people believe that running shoes make you run in a rear foot manner. And certainly the other thing is true. Barefoot running makes you run in a forefoot striking manner. But we'll return to that one a little later on. And then much more recently with the Born to Run phenomena, that the Tarahumara run barefoot or in sandals, and that's pretty much the same argument as hunters never wore shoes. So those are a few of the typical arguments that you find. Another very interesting one is that the incidence of running injuries has not changed over the last 2 decades. And this, I think, deserves some further study. Unfortunately, we don't have a well-designed study of an at-risk population that is what you would call a true epidemiological study where you assess risk based on exposure. We don't have a study that has been going long enough. There are some classic studies. There are, of course, the studies of Stan James. There are the studies of Jack Taunton, your colleague, Chris, and they do tend to suggest that as footwear and training methods have evolved, about the same number of runners are getting injured. And the implication taken there is that it's the advances in running shoes have not been able to reduce the number of injuries. But the fact is that the population of runners have changed in the last 20 years. When I was running the Boston Marathon more years ago than I tend to remember, I finished in about the top 500. Now, to finish in the top 500 today, I would have to be Kenyan for a start, and we'll get to that. But not quite, but I'd have to be running sort of 2:15. And now you've got people who their goal is to run 5 hours. I mean, that's barely running. But they're doing it, and it's great that they're doing it because it's become the modern challenge. We don't have to go out and kill meat for our family anymore. So we're we lost the great challenge in life, and so now we choose them, and we either we climb Everest, or if we're not that rich or that adventurous, we run a marathon. So just because the incidence of running injuries hasn't changed, that's not a good argument because the population has totally changed. So we're left with a bunch of arguments, some of which have merit and some which can be argued about, but none for which there's really good evidence base. So let's get directly to an example where industry told us what to do. And so these are the Vibram shoes, and their advertisement from 2005 specifically said these shoes will strengthen foot muscles while reducing running injuries. Now, let's take these two claims to begin with, strengthen foot muscles. That may be true. Peter Bruggemann at the Sporthochschule in Cologne did a very interesting study when Nike Freeze first came out. And he took a group of students and randomized them to students who, during a warm-up period for their track workouts, they would exercise in these minimalist shoes, and the control group would exercise in conventional shoes. And they did this over a long period of time, and he did MRIs, similar to the ones I was talking to you yesterday about, of the intrinsic muscles of the foot. And whereas I, in my studies of intrinsic muscles of diabetic patients, found that they basically didn't have any when they had advanced neuropathy, what Peter found is a significant increase in the diameter, cross-sectional area of the intrinsic muscles of the foot in minimalist footwear. So it does seem that what happens when you wear minimalist footwear is that your foot has to do much more, has to apply much more force, much more foot activity to cope with keeping a foot stable on multiple terrain. So it may well be true that minimalist footwear or barefoot walking and running may strengthen your intrinsic muscles of the foot. But this claim, reducing running injuries, turned out to be overwhelmingly false and dead wrong. I'm sure you're all familiar with these. They're shoes which basically just have 1 to 3 millimeters of plantar aspect. They have no differential between the heel and the toe, and they're just really like a water shoe. So it took a while because that claim was in 2005, but in 2013, last year, Sarah Ridge published this paper in Medicine, Science, and Sport and Exercise. And what she did the same as Bruggemann. She randomized a group of 36 runners to run either in the minimalist Vibram shoes or conventional shoes while they did a training program for 10 weeks. And what she found was, her methodology was MR, and in the MRs, she looked for bony edema. And here, in this navicula, you see an example of bony edema. In the blue, you see the number of cases of bony edema from grade 1, 2, 3, and 4. Now, grade 1 is not necessarily considered a bone injury. It could be just reflective of turnover, increased turnover, which could be a good thing. But grades 2, 3, and 4 are considered stress reactions and precursors of stress injuries. And you can see that what she found was that in the traditional shoe in blue, there were just 11 cases of bony edema. Whereas in the five-finger shoe, there were 32 cases at grade 1, there were 12 cases of grade 2, 5 of grade 3, and 2 of grade 4. So there was an overwhelming tendency to cause bony injury in subjects who had been randomized to wearing the control shoe. And so this led to the great recall. Here from Military Times is a discussion of how Vibram actually had to agree in a lawsuit to pay back every single consumer who'd ever bought these shoes, and they gave back the money. But so here's a great example of industry telling us with no evidence whatsoever that this would reduce injuries, and they turned out to be dead wrong. An interesting and a postscript that I don't quite know how to deal with is that actually in a subsequent survey, they asked more than 1,000 Vibram owners after the lawsuit, and they said, well, 70% of those said they're going to continue to wear them. So I don't know how you square those two things. I guess it's like smoking. You know it's bad for you, but gosh, you're still going to do it. So that's one example. Now, ironically, just about a couple of weeks ago, as I was putting a few slides like this together, I got this email in my inbox from the shoe store where I buy my own running shoes. And so this one refers to the great new trend. This one, the shoes are maximally cushioned. So now the response to this is, oh gosh, so that didn't work, the minimally cushioned. We better now tell them it's maximally cushioned. So these great shoes not only are maximally cushioned, but they also have a lower heel to toe height difference. Now, who says that's a good thing? Are we going to have now more cases of Achilles tendonitis and posterior inflammation? But here they are. The pendulum hasn't just drifted, it's completely swung. And we're now being told that this is what we need. We need maximally cushioned shoes with a heel to toe height difference. And they've said that this is the natural, quote, this is how I was born to run feel. So what a tremendous conflation of the previous claims and the new theory. And this is the low drop that puts your foot perfectly parallel to the ground. So I think I made my point. Your patients are going to listen to this stuff. They go into the shoe stores. They're going to be told this stuff. They're going to come to you and they're going to say, so what do I do? So I won't tell you what you've got to do yet, because we're going to explore that. All right, so what about emulation? Do you simply point to trends that are working for other people? And certainly for your marathoners who come to you, running like a Kenyan seems like a darn good thing to do. London Marathon 2012, Uganda, Kenya. Boston Marathon 2014, an American of African origin, Kenya. But the studies that have looked at Kenyan runners are really very interesting indeed. We usually think that running economy is the most important thing in a marathon distance, not shorter distance. And I'll talk a little bit about that in my next slide. But a study in the Journal of Sports Science this year showed that actually there's a complete dissociation between race performance, and running economy in Kenyans. And so it's still a very open question of whether it is just the prolonged exposure and a genetic modification to high altitude living that has not yet been elucidated that is causing these Kenyan runners to run. And if, for example, running style was to be copied, this is a little running history that I want to show you here from my very, very early history. In 1974, I was involved in a study at the Dallas Aerobic Institute of elite distance runners, and one of the subjects in this study was Steve Prefontaine, who you may have seen some of the films and this work was published in the New York Academy of Sciences. But this is a interesting little clip of movie. The guy on the left with the hair is actually me, and there is Steve Prefontaine running on the treadmill at about 5 miles an hour with just an incredibly vigorous, robust running style with big leg swings and a very unusual running style. And one of my former graduate students and colleagues, Keith Williams, has actually taken this video and has studied and compared some of the results of it. And he's found that, first of all, physiologically, Pre was an incredibly elite consumer of oxygen. He had a higher VO2 than any of his colleagues, but he was very inefficient. His kinematic characteristics were substantially different from the other elite runners, and they were similar to those that correlate with poor economy. And so, for example, emulating a running style of a runner like Prefontaine, therefore, would not be a great idea. It seems that he ran fast despite his running style and because of his abnormally high and exceptional physiological capabilities. Another very famous example is Emil Zatopek. Emil Zatopek was still the only runner to have won 5K, 10K, and marathon at the same Olympics. That's soon to be broken, I'm sure. But there was a reporter for the Philadelphia News called Red Smith, and he wrote that Zatopek ran like a man with a noose around his neck, the most frightful horror spectacle since Frankenstein. On the verge of strangulation, his hatchet face was crimson, his tongue lolled out. Well, that's a little bit of over-the-top journalism, but you get the idea. This guy had a terribly ugly running style, and yet he was the most successful runner of the era, and still his feats have not been emulated. So it seems that copying styles is not a great idea either. Armchair science. How about armchair science? Well, one that I picked out that you may have seen is this one. It's called Chi running. It's very new age. And this is a movement, I would call it, that allows running never to feel so good. That it says it's helped thousands of runners transform their technique, reducing, preventing, and recovering from injuries. It's improved efficiency and performance. It's pain-free, easier, and enjoyable. So everything you could possibly wish for in a way to run is embedded here in Chi running, which is a combination of meditation and running and changing running style. And I know I'm treading on your territory here, but hopefully I'm giving you a nice introduction to modification of running gaits. So this is an example of armchair running that, where did it come from? Where did it come from? Certainly there's no science in this, but people are doing it, and some of them will come to you and say, well, should I be Chi running? And so that's a typical example of what you want. Well, let's turn to how science and medicine might impact your decisions, because we would ideally think that this would be the source from which you derive your primary knowledge base. These are illustrations from one of Lieberman's papers, and the question that I'm now turning to is, what is the best foot strike pattern? Now, you're all aware, I think, with about the measurement of ground reaction forces. Yesterday we talked about the measurement of pressure distribution. Measurement of ground reaction forces involves with the forces you can measure from a force platform, shown here in what's now become known as a butterfly diagram, from the way the ground reaction force vector during walking, not running, but during walking, looks a bit like the wings of a butterfly. And if we look at ground reaction forces, and here what you're looking at is a ground reaction force in units of body weight against contact time, 100% of contact time, during running with a rear foot strike, a mid-foot strike, and a forefoot strike. And this notched one is the rear foot strike, and the two others are pretty indistinguishable, the midfoot and the forefoot. And all of the attention here has been devoted to this first peak of the ground reaction force, which has variably been called the impact peak, the active peak. There's a very excellent paper by Martin Shorten in Footwear Science in 2011, which I think is one of the best papers about running mechanics that there has ever been, where it's a very provocative title. It says something like that: the impact peak in rear foot running is neither impact nor strike related. It's a very provocative paper, and he explains this in a way it's never quite been explained before. But this peak is important because many people have used the existence of this first peak to suggest that this peak, characteristic of rear foot running, suggests that rear foot running is a bad thing, and that is something that, if that's present in a runner that comes into your practice, you've got to get rid of it. Now, this is a problem because it's been shown, for example, that by taking just movies of marathon runners, thousands of them, and this is some of Martin Shorten's work as well, that over 90 to 95% of people are rear foot strikers. Now, that's not to say the runners who are at the front of the pack doing 2:08, 90% of them strike this way, but 90% of the people that you will see in your practices are going to be rear foot strikers. So does this mean that these are all people that you need to change and tell them that they shouldn't strike this way anymore, just because this rather poorly understood first peak of ground reaction force is something that one might suggest one could get rid of? And here is a paper from Nature that was published in 2010, where again the evolutionary hypothesis was leaned on. And I always think that the burden of proof in anthropology is very low. I shall never forget an event that happened not a mile or two from here when I was a graduate student. There was a very, very famous anatomist who I think was knighted subsequently, Sir John Napier. I don't know if any of you remember him. He gave the Royal Institution lectures once, actually, the Royal Institution just across the road from here. And we used to have tea in the morning, as everybody does, and the only difference that our tea was right off the dissection room, so it was kind of tea and formaldehyde. But he would come in, and he had a little Swan Vestas matchbox, and he shook this matchbox, and he said, he had, I don't know, he had a respiratory disease. And he said, and he emptied this matchbox on the table, and a tiny little bone fossil actually came tripping across the table, and he said, "So how did the owner of this walk?" And it was this tiny little distal metatarsal. And he then proceeded to launch into a 15-minute speech about how the owner of this bone was clearly bipedal and had hunted this and ate that. And it struck me at the time, and it's always stayed with me, well, who's going to prove him wrong? The burden of proof is just different for anthropology than it is. And so what I feel about this, Lieberman's a very interesting man. I was just at a meeting with him a month ago, and he's got some really interesting examples of how running was important in an evolutionary context. One of the most interesting of these videos was how to kill a gazelle if you need to. And you might at first think, well, that's ridiculous. Humans are never going to run after a gazelle. But it turns out you can. And the way you do it is, first of all, you choose your time. You choose the hottest time of the day. Then you find a gazelle. That's obviously necessary. And you start running after the gazelle. And so the gazelle runs away, and then it stops. So you see where it went, you run again. And you keep repeating this until eventually, maybe on the 6th or 7th or 8th time, gazelle just lies down in front of you in total heat exhaustion, but you're still going because the human has developed this ability. So that's just one example of the fascinating example of how running was a critical component of human survival and human evolution. But that doesn't, to me, say that we've got to be running barefoot. Who's to say that you couldn't have done it better if you're wearing a pair of Adidas spikes? So anyway, that's the whole issue related to the evolutionary argument for foot strike. And you can see here that this is, as we talked about, the rear foot strike, and this is the forefoot strike, the rear foot strike and the forefoot strike. And these are rate of loading, and this one is peak force. That has been used to imply that because these are higher, this is less. Now, we have taken a different approach to this, and we have been looking at body-mounted sensors. I think you're aware that there has been just an amazing revolution in body-mounted sensors. It's not going to be long before we are monitored, all parts of our body are monitored in many ways online. I'm involved in another project where we're monitoring patients post-surgically, where we're looking at the movements of the joint, the new joint they've just received. And so this is an example where small accelerometers are attached to the anterior tibia of women distance runners as they ran in different ways. In one experiment, we used 32 women distance runners. They were all training for a race. They were age about 28, body mass about 60 kilograms. And we studied them at fairly low running speeds because these were not elite runners. These were women who were just training to run a 10K race. And we measured them in their preferred shoes. We've done other experiments where we gave them the shoes, but what I'm going to show you is women running in their preferred shoes. So what you get is you get a continuous pattern for every foot strike. This is like a minute of running on the treadmill. So rather than just one foot strike across the treadmill with body-mounted sensors, You can record for a minute, an hour, a day, 10 days, and so you can really get a very good picture of the certain mechanical characteristics of the run. And then from that, you can average these together. On the bottom, we've got the ground reaction force, because this was done on a treadmill that had an embedded force plate. And you can see that this was very much a rear foot striking pattern in this person. And this is the resultant tibial acceleration. This is 10 Gs up here. And you can see that coincident with foot strike, there is a shock wave that travels up the body, and you can measure it at many different places. You can actually measure its transition from the tibia to the lumbar spine. A very good way to measure it too is to measure a bite bar, because if the patient clenches on a bite bar, you've got a pretty good connection with the skull, and so you can look at the implications of something happening at the feet for flowing up the whole body. Now, you have to do a bit of math on it, because the accelerometer is pointing in its own direction, and you want to know the components in the direction of the anatomical planes, but that's all possible. When we first started this, I must say that I wasn't really a fan of accelerometers on the body. I always thought that it was a bit like if you had a plate of Jell-O and you wanted to know what the plate was doing, and you put an accelerometer on top of the Jell-O. You wouldn't learn very much about the plate. You'd learn a lot about the characteristics of the Jell-O. But this is a reliability experiment where on 2 successive days we measured the peak tibial accelerometer, day 1, day 2, and you can see that we have an R squared of 0.92. This is a very reliable technique. So you really can, and this was taking the sensor off, putting it back on again, you really can get good measurements. Now, I've got 3 components behind the bar, but I just want to show you this one. So this is the resultant acceleration, the peak acceleration that the tibia experiences during midfoot running in red and rear foot running in blue. So what's going on here? We saw that the peak of the ground reaction force, there was a peak in rear foot running, and there was no peak in midfoot running, but here we find completely the opposite. That if you run with a mid or forefoot strike, your tibial acceleration resultant is significantly higher. And that's the key, resultant, and I want to show you an example of that. Another way you can do this is, instead of finding rear foot strikers and midfoot strikers, you can take the same runner and get them to change their pattern. And so on the left, you see a woman runner. Let me just get the mouse in the right place here. So this is her normal pattern. She is a fore to midfoot striker. She certainly doesn't strike with the heel. And her right foot sometimes doesn't touch the ground there. And the typical pattern of ground reaction force that you see is there on the left. Now, here she is. Let me get her going again. She doesn't want to run. Yes, she does. So here she is when we ask her to change to a rear foot pattern. So here you see she has a very typical rear foot strike. And there is her pattern of ground reaction force, which has that initial notch. Now, here is the acceleration vector that her tibia experiences. And this is in her conventional forefoot strike, and this is in her altered rear foot strike. And you can see dramatic reduction when she goes to a rear foot strike. Now, why is that? Well, you can see that what's really the difference between these two is how the vector swings out and has a greater AP component. And when you think about it, when you run on the forefoot, you are totally preventing that natural rollover mechanism of first of the plantar flexion and then dorsiflexion. You're stopping that happening, and you meet the ground with a huge sort of thud and a resistance, because you don't have a joint that's going to help you with that transition when you strike forefoot. So even though you're missing that first peak of ground reaction force, you're certainly missing this when you run forefoot. But when you run forefoot, you've got this huge AP component which really increases significantly the shock on your tibia. So this is not the whole story, but at least this shows that taking a single piece of evidence, the ground reaction force, and deciding you better change your running style is not good evidence that that is what should be done to reduce injury or to improve the runner's economy or speed. So here's the dilemma then, to bring this all together now as we get towards the end for you as a clinician. Of course, you want to be on the front of the wave with new treatments. When your patients come to you and say, have you heard of this? You don't want to say, well, no, I actually haven't. What's that all about? Or you want to know the best evidence you can about whether the flavor of the month, which, as we have seen, has been minimalist shoes and barefoot running and rear foot striking, whether these things really are helpful, whether they really are preventative. Your patients have definitely read all about them, and they're on the web. The media absolutely knows that the latest paper is the best evidence because they're always looking for new things. Your competitors, or colleagues I should perhaps say, but let's be truthful, your competitors are recommending these treatments, and so they're going to go to get a second opinion and be told they're great. And unfortunately, a careful review of these new approaches, maybe 3 or more years in the future. So what are you going to do? Well, are systematic reviews the solution? And there has been a tremendous tendency led in the United Kingdom for systematic reviews, particularly by the Cochrane collaboration that started in York, as you know, at the University of York. And the latest we have on preventing running injuries is this review by Young and Gillespie from 2011, interventions for preventing lower limb soft tissue injuries, which are the injuries we're mostly worried about. Sometimes it's stress injuries in the bone, but soft tissue injuries are what we need to prevent. So the approach in a typical Cochrane review is this. You do and I talked about it a little bit yesterday in the diabetic foot context because I have been involved in one of these. And so you open the doors as wide as possible. You try and search every possible electronic database you can. You study Web of Science, you study Medline, you study every Embase, you look at every place you can. But you only include randomized or quasi-randomized controlled studies. This is where we are. Observational studies, case series, no longer count at all in the weighting of the evidence in an evidence-based context. And this has changed science in a lot of ways because you don't want to spend a lot of time doing a study that's never going to make it above the threshold gate for evidence that's going to have an impact on practice. So throw away everything except the randomized or quasi-randomized control studies. 2 reviewers independently review each of the papers for quality and risk of bias. And optionally, there's a meta-analysis where you don't just report, but you actually combine the results of all the studies in a statistical model so that you do a mega experiment that could never be done by a single individual. So what did this particular review of running soft tissue injuries report? And you better put your seatbelts on because this is rather depressing from a treatment point of view. They found 25 randomized controlled trials with a total of 30,000 participants. That's a lot of people. And of course, it included some military trials where whether subjects were volunteers or not could be debated, but they certainly were in the study. This is a holy grail of running. They found absolutely no evidence that stretching reduces lower limb soft tissue injuries, and that includes 6 trials with 5,130 participants. Now remember, these were not observational studies where you just ask somebody and say, well, did you stretch before the race? These were randomized controlled trials where people before the race, they were randomized to say, don't you stretch? And these were said, yes, you definitely stretch, and this is what we want you to do. Now, it's possible that the stretch was the wrong kind of stretch, and so you really have to look at the treatment, but there's no more holy grail in advice to runners than stretch before you run. But the evidence from randomized controlled trials suggests that this is not the case. Now, I should mention very early in these litany of no evidence that I'm going to show you that it doesn't mean it's not the case. It means that so far no study has been done, perhaps you could say no study has been done correctly, that can reveal an effect here. But certainly these were smart people who did these studies, and they seem well designed, and there's no evidence. It gets worse. No evidence that a longer training program with a gradual increase is more effective than a shorter program. And now this one, by the way, is for people planning to do a 4-mile run, which is typical in a military context. And so this is very traditional evidence. So you should build up slowly. You should gradually increase your mileage. Another chestnut that we always say, no evidence for that. Now, you'll be pleased at this one. Custom-based biomechanical insoles may be more effective than, wait for it, no insoles. So that's not a great test. That's saying shoes with nothing inside them, these that a custom-made insole may be more effective than nothing in reducing medial tibial stress syndrome, but there is no evidence to support the use of shoe insoles for the reduction of other lower limb soft tissue injuries, whether they're individually prescribed or off the shelf. This is a very depressing state of the art for a group of people such as us who feel like you've got to intervene and we know what to do to prevent these soft tissue injuries. So overall, this Cochrane review, which is the best we have at the moment, says the evidence for the effectiveness of interventions to reduce lower limb pain after intensive running is weak, that more trials are needed to confirm these findings, especially in recreational and competitive runners, typical of those you treat, rather than military recruits. So not the best of situations. I've shown you where you shouldn't take evidence from. Then we got around to where likely you would have thought I'd be telling you you should take evidence from, and then we look at the evidence and find that it's really not great. So I look forward to talking with you about where to go from here. I don't really have time to show you my last little bit of vignettes of running on the moon, but what we talked about today is where you get your information from, how you synthesize it, how you interpret it for your patients, and how evidence should be used in your practice. So that's really what I have to say. Thank you very much indeed.